Today we will discuss the explain why anemia occurs after gastrectomy. So we have to know what is anemia and what is gastrectomy. Okay. So what is anemia or what is the definition of anemia? You have to know it because in every year or in every exam, what is anemia? This is asked. Okay. So what is anemia? Anemia is the qualitative or quantitative diminution of RBC or hemoglobin or both in an individual with respect to age and sex, and it is clinically manifested by pallor. So we have known the definition of anemia. Okay, write down this definition. Now come to this, what is gastrectomy? Okay, here gastrectomy there is two terms. One is gastric and another is tomy. So what is gastric? Gastric, you know that having to do with stomach is known as gastric. Suppose a patient has stomach ulcer, it is known as gastric ulcer. Suppose a patient has inflammation in stomach, it is known as gastritis. Okay, so any relation with the stomach is generally start with this gastric. So what is tomy? Tomy means not Tommy Hilfiger. Tomy means surgical excision of any organ or part of the body. Okay. So here is gastrectomy. It means the surgical removal of the stomach. So gastrectomy means surgical removal of stomach. So we have to make a relation with gastrectomy and anemia. Clear? Okay. So what are the indications of gastrectomy? Is it commonly done in regular practice basis? Suppose a patient came with abdominal pain and will you advise him to go for gastrectomy? It is not generally advised. So what are the indications? Indication, basically most common indication are the gastric carcinoma. Okay, and another nowadays it is being most popular nowadays, that is, so we are discussing what are the indication of gastrectomy. First is gastric carcinoma. Nowadays that is getting popular, that is when patient has severe obesity. Ambani. Okay. So when patient has getting severe obesity, generally doctor advised him to go for gastrectomy, or it is known as bariatric surgery. Okay. What we do in bariatric surgery? Generally, in bariatric surgery, suppose this is the stomach, and in bariatric surgery, this portion of the stomach is cut and the stomach become this kind of smaller in size. Okay. So what are the benefit of this bariatric surgery? And here we notice that patient came with severe obesity and we do bariatric surgery. Here we reduce the size of the stomach. So what is the benefit? The benefit is that if we reduce the size of the stomach, so definitely it decrease the hunger and increase the feeling of fullness after taking a small amount of food. So generally patient will take less amount of food. Okay, and that will help to reduce his obesity. Now come to the, we will try to relate with the anemia and gastrectomy. So there is decreased hemoglobin or RBC after removal of stomach. So what are the relation? Is the hemoglobin or RBC are producing from the stomach? No. So RBC or hemoglobin are not producing from the stomach. So what are the relation? We are removing the stomach and patient is having anemia. Okay. Now we will try to identify the relation. Okay. So from where the RBC or hemoglobin is? From where the RBC or hemoglobin is produced? Does it produce from the stomach? No. So hemoglobin or RBC is produced from the bone marrow. We know that there is two kind of bone marrow. One is red bone marrow and another is yellow bone marrow. And yes, it is present in all human beings, not only in the body of East Bengal supporter. Okay. So where red bone marrow are located? This is asked in Viva. Generally, you know that red bone marrow are found in the axial skeleton. Where at the axial skeleton, mainly the sternum, ribs, vertebra, pelvis bone, and end of the long bone like humerus, femur. Okay. What is the function of stomach? So what are the function of stomach? After that, we will try to relation with the gastrectomy with the anemia. You know, in Viva, if it is asked what is the function of stomach, and another time it is asked what are the essential function of stomach, two are different things. What is the essential function of stomach? The answer will be another. And if they ask what is the function of stomach, the answer will be another. Okay. So what is the function of stomach? We all know the main function of stomach is the temporary storage of food. Fine. Another function is grinding and mixing of food. Third function, HCl secretion. The HCl is secreted from the stomach of the parietal cell, and this HCl has some kind of function. This HCl helps to convert pepsinogen to pepsin, and another what HCl do? Some HCl also convert from ferric form to ferrous form of iron, and this ferrous form is absorbed in the intestine. Another function of HCl is to kill microorganism. Okay. And another function of stomach is it secrete intrinsic factor. It secrete intrinsic factor, and this intrinsic factor help in absorption of vitamin B12. Okay. And last function of stomach is it also absorption of H2O and lipid soluble substance, as like it also helps in absorption of alcohol. Clear? And last function, the stomach also helps in emptying of food, or it also control emptying of food. Okay. Now you have to relation with the stomach, function of the stomach with the anemia. So in which function, if it is disrupted, it will affect in or it will lead to anemia. Definitely if there is temporary storage of, if there is no temporary storage of food, definitely there will not be anemia. If there is no grinding and mixing of food, definitely there will not be anemia. If there is decreased HCl secretion, then it leads to anemia. How? Decreased HCl secretion means decrease conversion of ferric to ferrous form, and ferrous form is absorbed, and you know that iron is essential in to formation of hemoglobin. So if there is less HCl secretion due to gastrectomy or partial gastrectomy, it leads to decreased ferrous form and it leads to decreased iron absorption. It means so it can lead to anemia. Okay, and the most important, if there is partial or total gastrectomy, there will be no secretion of intrinsic factor, so there will be no absorption of vitamin B12, and this vitamin B12 has a role in RBC production. We will discuss it later. Okay, now so we have come to know, so if there is partial or total gastrectomy, there is decreased HCl secretion, decreased intrinsic factor, that leads to anemia. Okay, so what kind of anemia we will see? If there is decreased iron absorption, there will be another kind of anemia, and if there is decreased vitamin B12 absorption, there will be another kind of anemia. Okay, so if they asked what are the cause of iron deficiency anemia occurs after gastrectomy, you have to mention the another point, and if they mention that megaloblastic anemia occurs after gastrectomy, then you have to mention this point. So now we will discuss about mainly the absorption of vitamin B12, and we will know how this decreased absorption of vitamin B12 leads to anemia or leads to megaloblastic anemia. Clear? Now we will know some little bit about the vitamin B12. Okay, so vitamin B12 is also known as cobalamin or cyanocobalamin. Cobalamin or cyanocobalamin, sometimes it is also called as extrinsic factor of Kazin. Extrinsic factor of Kazin. Okay, now what are the source of vitamin B12? What are the source? Vitamin B12 has mainly animal source. Animal source, we get vitamin B12 from the meat, egg, okay, liver, and milk product. Vitamin B12 absent in plant food. I am saying again, it is absent in plant food. Okay, so clear? What is the daily requirement of the vitamin B12? The daily requirement is 3 to 4 microgram per day. Okay, and absorption. From where vitamin B12 is absorbed? It is mainly absorbed in the terminal ileum. Okay, now we will discuss how vitamin B12 is absorbed or the mechanism of absorption. Okay, discuss how vitamin B12 is absorbed. We know that vitamin B12 is present within the animal product. Suppose this is vitamin B12 and it is present inside this inside the chicken fish. Okay, Now vitamin B12 is present inside this chicken piece, and when we chewing inside our mouth, our saliva secrete one product. It is known as covalophyllin. Okay, our saliva secrete a product known as covalophyllin. Okay, now covalophyllin is secreted in the saliva. Okay, now after we swallowing out food, and now food, vitamin B12, which has bonding with the protein, now comes inside the stomach. Clear? Okay. Okay, and this covalophyllin also came inside the stomach. Okay, but suppose there is a love story like scene. In this love story, this covalophyllin is an actor, and this vitamin B12 is an actress, and we all know that in all Hindi movies that actress has a bodyguard, maybe the bodyguard maybe his father or mother. So there you can see this vitamin B12 has a bodyguard. It means it has a structural bonding with the protein. So here covalophyllin cannot attach with this vitamin B12 because bodyguard is present. Now both the vitamin B12 with his bodyguard and covalophyllin comes inside the stomach. Okay, so here what happened inside the stomach? In the stomach, you know that there is parietal cell, and parietal cell secrete HCl. Okay, so there is parietal cell inside the stomach, and it secrete HCl. Now HCl is basically a friend of the covalophyllin. Where a male actor has many kind of friend, so HCl is also a friend of covalophyllin. Now HCl will come and try to destroy the bodyguard of the actress, or HCl will now destroy the relation with the protein of vitamin B12. Okay, now sometimes this HCl alone cannot destroy the bodyguard, so HCl needs a help. HCl needs a help of pepsin. We all know that. HCl is also help in convert of pepsinogen to pepsin. HCl will convert pepsinogen to pepsin, and this pepsin will come and destroy the relation with the vitamin B12 with the protein structure. So we came to know that both HCl and pepsin will release the vitamin B12 with his bodyguard. Now vitamin B12 is free. Okay, here another actor come in this story. The name of this actor is intrinsic factor. The parietal cell also secrete intrinsic factor. Now there is one actress and two actors. Vitamin B12, which is now free, and covalophyllin is present, and intrinsic factor is present. Intrinsic factor is also is an actor. Now what this vitamin B12 will do? Definitely vitamin B12 or this actress will go along with the covalophyllin because it was present from the saliva. Bachpan ka pyar. Okay. Now vitamin B12 is along with this or bind with this covalophyllin. Okay. So there is a relation with the cobalamin with the vitamin B12. But this intrinsic factor will not lose his hope. He will come along with this cobalamin and B12. Okay. Now this cobalamin with vitamin B12 along with intrinsic factor comes to the duodenum. Now in the duodenum, there is cobalamin with B12 and along with intrinsic factor. We know that there is intrinsic factor, and this intrinsic factor also comes into the duodenum. Now here in the duodenum, now pancreas secrete pancreatic juice, and they mainly secrete trypsin. This trypsin comes into the duodenum through pancreatic duct and destroy this cobalamin. Okay. Now there is no bonding between the vitamin B12 and cobalamin. Now B12 is released. So what B12 will do? Now B12 will release from there, and now vitamin B12. We know that this is actress B12 and there is two actors. Now one actor is died, cobalamin. Now this actress now bind with the intrinsic factor. So we know that intrinsic factor release in the stomach by the parietal cell, but B12 bind with the intrinsic factor in the duodenum. Okay. Now there is a new love story of B12 plus intrinsic factor. This is a new love story. Now this B12 and intrinsic factor along comes in the terminal ileum. Okay. Now in the terminal ileum there is a receptor. Okay. Now in the terminal ileum there is the receptor, and here in this receptor the bonding form of B12 and intrinsic factor binds with this receptor of the terminal ileum. Now what happened there? Now here happened that B12 now absorbed in the intestinal mucosal cell. Now B12 is absorbed. Clear? So we have know that here B12 is present inside the mainly an animal food, and now B12 comes, and here in the terminal ileum B12 is absorbed. Okay. Now what will happen? Now B12 is absorbed. Now here B12 comes into the circulatory system. Here a transport protein present. The name of the transport protein is transcobalamin. So there is transcobalamin. These are the transport protein. Transcobalamin. There is three type of transcobalamin present, 1, 2 and 3, but most important is transcobalamin 2. So here B12 bind with this transcobalamin. And what will the fate? After that, this transcobalamin along with vitamin B12 is comes into the liver, and in this liver B12 is stored. Okay. So now here vitamin B12 is vitamin B12 is stored as a form of deoxyadenosine cobalamin. Okay, fine. Now B12 is present inside the liver as a form of deoxyadenosine cobalamin. Now we will know how much amount of B12 is stored in the liver, and the amount is 4 gram of vitamin B12 is stored in the liver. And in the early class I have discussed that daily requirement of vitamin B12 is how much? The daily requirement is 3 to 4 microgram. Okay, and here how much vitamin B12 is stored? 4 gram or 4000 microgram. Okay, now I can calculate an easy math. Suppose a patient stop his vitamin B12 content food. Daily requirement is 3 to 4 microgram and the storage 4000 microgram in his body. Now if he suddenly stop intake of vitamin B12, okay, so what will happen? So this 4000 microgram of B12 will be finished in how much days? It will finished in, suppose there is 4 gram is requirement, it will be finished in 1000 days or generally 2.7 years. So if a patient or if a person stop vitamin B12 containing food, then all the stored vitamin in his body will be finished after 2.7 years, generally 2 to 3 years after. Okay, clear? Now we can relate that the deficiency related to vitamin B12 will occurs after 2 to 3 years, okay, after stopping of intake of vitamin B12. Clear? Now B12 is stored inside the liver, and now we know that vitamin B12 is necessary for production of RBC. Okay, now I will draw a sketch of bone marrow house. Suppose this is a bone marrow house. Okay, and in this bone marrow RBC is produced. Okay, now what will happen? Now B12 is stored in the liver and it comes into the bone marrow. B12 helps in production of RBC. Okay, inside the bone marrow there is already present of methyl tetrahydrofolate. In the bone marrow there is already present of methyl tetrahydrofolate, and folate means that folate that is absorbed in the jejunum, and this comes in the bone marrow, and in bone marrow it is present as a methyl tetrahydrofolate, and inside the bone marrow there is also presence of homocysteine. Now what happened? Now B12 comes in the bone marrow. Okay, here one reaction occurs, that is what B12 do is that B12 take this methyl part of the tetrahydrofolate. Now it becomes methyl B12, or now it becomes methyl cobalamin, and methyl tetrahydrofolate is now free and it becomes only tetrahydrofolate, and this is the active part of this tetrahydrofolate. Now tetrahydrofolate is free from methyl and it is now active. Okay, and then what will be the fate of this methyl cobalamin? And this methyl cobalamin now helps in Now methylcobalamin helps in this methyl group is transferred to the homocysteine. Now homocysteine become in methionine. Okay, so we know that if vitamin B12 cannot come, the methyl tetrahydrofolate cannot be converted into the tetrahydrofolate, and this is the active form. So folate will not be active if vitamin B12 is decreased. Okay, and we can say if vitamin B12 is decreased in amount or vitamin B12 is deficiency, then B12 cannot be converted to methyl B12, and if methyl B12 or methylcobalamin cannot synthesis, so it cannot help in the synthesis of homocysteine to methionine. So there will be decreased amount of methionine. So I can say if there is deficiency of B12, there will be deficiency of methionine and there will be deficiency of tetrahydrofolate. Clear? Now here one question is asked, what is folate trap? We know that in our life there is 4 type of trap. First trap was your NEET, second trap will be your NEET PG, third trap is folate trap, and fourth trap will be your marriage. Okay, now what is folate trap? Folate trap means if there is deficiency of B12, it leads to accumulation of methyl tetrahydrofolate inside the body. So methyl tetrahydrofolate cannot be synthesized into the tetrahydrofolate. Okay, so it accumulates inside the body. It is known as the folate trap. Clear? I think. Okay. Now, what is the function of this tetrahydrofolate? The function of the tetrahydrofolate mainly is it helps in formation of ribonucleotide to the deoxyribonucleotide. Okay? It helps, the tetrahydrofolate helps in. Okay, I am writing it here. The tetrahydrofolate helps in ribonucleotide to deoxyribonucleotide. So, and we know that deoxyribonucleotide is essential in the formation of DNA. So, in the absence of tetrahydrofolate, there will be the less amount of DNA synthesis in the body. There will be the RNA synthesis, and it will helps in the protein synthesis. So it means when there is cell division occur, what happened? You know that you have read in the NEET that at first there will be the increased amount of protein synthesis. It means increased amount of the cell organelle. And after that, what happened? The number of DNA increase and then cell division occur. So here we can see in the deficiency of tetrahydrofolate, there is increased synthesis of RNA. It helps in the increase the amount of the cell organelle, but there is no increase in the DNA. So cell division will not occur as it occurs in normally. Okay. So, decrease in DNA synthesis, cell division cannot start. So, there is what happened? The cell will be in larger in size because the cell cannot divide further. If cell cannot divide further due to that there is decreased amount of DNA, the size of the cell is increased. Okay. This is known as the megaloblastic anemia. Okay, it means the RBC, that the size of the RBC is increased. Okay, fine, due to the deficiency of the tetrahydrofolate, and it occurs due to the deficiency of B12. Okay, clear? Okay, and another now comes to the what happened in the deficiency of B12. We know that in the deficiency of B12 there is deficiency of methionine. And what is the function of the methionine in our body? This methionine helps in the transfer of phosphatidyl ethanolamine to the phosphatidylcholine. This methylamine helps in the phosphatidyl ethanolamine to the phosphatidylcholine. Methionine helps in the conversion of this phosphatidyl ethanolamine to the phosphatidylcholine. And what is the function of the phosphatidylcholine? The phosphatidylcholine helps in the myelination of neuron. Phosphatidylcholine helps in the myelination. Myelination of the neuron. So if there is decreased amount of B12, there will be decreased methionine, and decreased methionine means decreased phosphatidylcholine. Decreased phosphatidylcholine leads to decreased myelination, and if there is decreased myelination of neurons, so what will be the problem? The problem will be their patient will suffer from the neurological problem. Okay, fine. So we have known that in the deficiency of B12 there will be the decreased tetrahydrofolate. It leads to the decreased RBC count, or it leads to anemia, or particularly say it is the mainly the megaloblastic anemia. And here we know that deficiency of B12 leads to the decreased myelination and neurological problem will be occur. Okay, now we will discuss what are the cause of this megaloblastic anemia, or what are the cause of the vitamin B12 deficiency. If you know that chart or picture, it will be very easy for you. Okay, so what if in the exam it is asked what are the cause of the megaloblastic anemia, or what are the cause of the vitamin B12 deficiency. So what will be the cause? First cause. Okay, now come to this picture. The first cause, if there is decreased intake of vitamin B12. So what are the cause of the decreased amount of vitamin B12? Mainly I have said that vitamin B12 has the mainly are in the animal source. So the pure vegetarian or pure vegan people are suffer of vitamin B12. So number one cause is the dietary cause, and in the dietary cause purely vegan people suffer with the vitamin B12 deficiency. So purely vegan people can have megaloblastic anemia or neurological problem. Fine. So we advise the patient that at least if you are vegan or vegetarian, at least try to intake milk or milk related product. Now I have a question for you. Milk or curd, which is the milk or curd, which is the comparatively, which is the better source? Milk or curd? Okay, fine. Now come to the second cause of this megaloblastic anemia. Now there is B12 is sufficiently present in his food, but patient cannot secrete cobalophyllin. So definitely it leads to the megaloblastic anemia, but generally it doesn't occur. So we will not write this point. So main point is we have known that B12 deficiency or dietary deficiency. Now come to the second cause. Now B12 and cobalophyllin comes inside the stomach. Now the second cause is, suppose there is patient has destruction of the parietal cell. Okay, if there is no parietal cell, there will be no intrinsic factor. No intrinsic factor means no absorption of the B12. Okay, and if there is absence of parietal cell, there will be decreased HCl secretion. Decreased HCl secretion means we know that HCl also helps in to break the bond of the B12 with the protein. So there will be no break of the bond. Okay, so if there is decreased parietal cell. Okay, so in which condition this parietal cell will be decreased? The most important cause is the if there is if there is autoantibody present against this parietal cell. Okay, we know that in the pernicious anemia, what happened? There is autoantibody present against this parietal cell and it destroys the parietal cell. So if there is destruction of the parietal cell, there will be no intrinsic factor and there will be no secretion of the HCl or hydrochloric acid. Definitely, if there is no secretion of intrinsic factor and no hydrochloric acid is present, vitamin B12 cannot be absorbed inside the body. Okay, and this is known as the pernicious anemia. So here you have to clear a confusion that pernicious anemia and megaloblastic anemia are not same things. Okay, pernicious anemia is one of the cause of the megaloblastic anemia. Okay, so when there is autoantibody presence against the parietal cell, it is known as the pernicious anemia. Okay. Now, in what other condition this parietal cell can be destroyed? And now this pernicious anemia is not common in India. Okay. So in India, if there is gastric mucosal atrophy in India, so I will write here is the pernicious anemia, but it is not common in India. In India, there is gastric atrophy. What happened in gastric atrophy or atrophic gastritis? Better to say atrophic gastritis. In the atrophic gastritis, there will be the decreased amount of parietal cell inside the stomach. This leads to decreased intrinsic factor and decreased hydrochloric acid, and it is commonly seen in the Indian people. Okay, so this also leads to the deficiency of B12. Fine. Now what happened? Okay, now there is condition. There is parietal cell is normal, but patient is taking what? Patient is taking. We know that in Indian condition there is the most common is acidity. So suppose a people is taking what? Antacid or any medicine that decrease the HCl secretion. We know that in commonly India we use pantoprazole, omeprazole. These are the proton pump inhibitor. So a long-term use of the proton pump inhibitor leads to decreased HCl secretion, and decreased HCl secretion means will be decreased conversion of pepsinogen to pepsin. Less pepsin means this pepsin also helps in the breakdown of the bond between the B12 and the protein. So B12 will not be free. There will be the B12 deficiency. Okay, fine. People also take some kind of histamine antagonist like cimetidine, ranitidine. This also leads to decreased HCl secretion. So decreased HCl secretion means there will be the deficiency of B12, or B12 will not be absorbed inside our body. Okay. Now what are the other cause? And the other cause where we have started is the gastrectomy. If we completely or partially remove the stomach, there will be no intrinsic factor, no HCl secretion. Then if we take the sufficient amount of B12, but B12 will not be absorbed. Okay. Now fourth point is our gastrectomy. Okay. Now come to the another cause. The fifth cause will be, suppose there is no gastrectomy, but there is insufficiency of trypsin. We know that all are present normally, but pancreas cannot produce sufficient amount of trypsin. So if trypsin sufficiently not produced, it will not destroy the bond of the B12 and the cobalamin. So B12 cannot bind with the intrinsic factor and it will not be absorbed. So our fifth cause is pancreatic insufficiency. Okay. Now sixth point. Suppose if we do a operation in the ileum, or the terminal part of the ileum is dissected out, it will not present inside the body. So what will happen? All the components are present, but it is not absorbed, because where it will be absorbed, we have removed it. So ileectomy, if we remove the part of the ileum or terminal ileectomy, leads to the megaloblastic anemia. Clear, I think. Now seventh cause, if there is inflammatory disease present inside the intestine, mainly the Crohn disease. It is very difficult to to know the concept, because it will be taught in the pathology subject. So just know that if there is any chronic inflammatory condition present inside the intestine, as example Crohn disease, it leads to decreased absorption of B12 and it leads to megaloblastic anemia. Okay. Now pregnancy, 8 factor. In the pregnancy, there is increased demand of B12. Okay. So in the pregnancy, there is increased demand of B12. If we cannot supply proper amount of B12, it also lead to the megaloblastic anemia. Okay. Now come to the 9th point. Fish step 1. What happened? This is not commonly found in India. It is found in the another country. In the fish step 1 condition, there will be the decreased amount of B12 absorption. Okay. Now we have known what are the cause. No need to mark up. Just clear the concept. It will be very easier for you. What are the causes of the megaloblastic anemia? So we have known anemia, megaloblastic anemia. We have known pernicious anemia. We know what is folate trap. Now there is one question is asked or explain why may come. Suppose a patient has, in Indian scenario, has atrophic gastritis. Okay, it means he has decreased parietal cell. It leads to decreased intrinsic factor secretion and decreased HCl. And the patient present as a case of megaloblastic anemia. So what will be the treatment? The treatment will be definitely, we will do B12 supplementation. Okay. The question is in which form the B12 will be supplied. Suppose a patient has megaloblastic anemia due to atrophic gastritis, and if we supply him B12 in the form of oral form, so we have advised the patient to take a amount of B12 tablet orally. So what will happen? We increase the supply of the B12 through orally by tablet. Okay, but B12 cannot be absorbed because there is decreased intrinsic factor and decreased HCl secretion. So it will not help in treatment of megaloblastic anemia. So what will be the treatment? We will supply the B12 in the form of intramuscular. So we will give intramuscular injection of B12. Okay. Now what will happen? If we directly inject this intramuscular route, this comes inside the blood directly. This route we have escaped. We supply directly the B12 inside the blood. Now B12 will be stored in the liver and B12 will be used in the bone marrow. Now this concept is clear, I think. Okay. And so we have discussed all the basic of this B12, pernicious anemia, megaloblastic anemia. Now we can easily explain why anemia occurs after gastrectomy. Now come to the another explain. If it is asked anemia, there if it is written that why why dimorphic anemia occurs after gastrectomy, if it is asked. Dimorphic anemia means in the peripheral blood smear we can see two type of RBCs. Some RBCs are larger in size and some RBC are smaller in size. It means two type of RBC is present. So this larger RBC means megaloblastic anemia, and means megaloblastic anemia occurs due to the deficiency of tetrahydrofolate, and it occurs due to the deficiency of decreased B12 inside the bone marrow. Okay, so and it occurs due to the gastrectomy. Now if they ask why it is dimorphic, dimorphic means two types of, why there is also a microcytic anemia present. Why there is microcytic anemia after gastrectomy? Okay, why? Because we know that in the gastrectomy there is also decreased HCl secretion, and this HCl secretion we know that in the earlier I have discussed, this HCl also helps in the conversion of ferric to ferrous form. So if there is decreased HCl secretion due to the gastrectomy, there will be the decreased ferrous form of iron, and this ferrous form is absorbed inside the intestine. So decreased ferrous form means decreased iron absorption, and decreased iron absorption means there will be the iron deficiency, and we know in the iron deficiency there will be microcytic anemia. So in the peripheral blood smear, two types of RBC we can see. One is the microcytic anemia we can observe, and we can see the megaloblastic RBC. So dimorphic anemia occurs after gastrectomy. If it is asked, you have to write all this. Okay, I think all the concepts regarding I have cleared. Okay, thank you.